So this discussion is going to look at the biomechanics around the head, neck, and trunk. So we're going to be examining movement at the various parts of the spine, look at how the ribs kind of interact with movement, and just again discuss some of the functional anatomy and how that kind of operates in this region. So if we look at spinal alignment and posture, first thing we notice is that our spine has natural curves, and what these curves actually do is they improve tolerance to axial compression. So if you remember at the beginning of the year when we talked about axial compression, so like an axial load, if you look at the laser pointer, an axial load is when kind of load is getting driven through, and the curves actually allow that to distribute the forces appropriately and limit injury in the case of an axial load. So, you know, one of the most devastating injuries we see in football players is when they take a blow to the top of the head with the neck without the neck in its natural curved alignment, and you end up having, you know, severe spinal cord injury at the cervical spine. So again, we have our curves. We have the cervical, thoracic, lumbar, and sacral. So as you look at that, we essentially have the lordotic lumbar curve, which is going to occur due to tension coming from the psoas muscle. The lordotic curves are what are deemed as secondary curves. So the two lordotic curves that we have at the cervical and lumbar spine, those kind of occur later in life. The thoracic curve is what's known as a primary curve. So the thoracic curve is a kyphotic curve, and that's something that, again, through development, you're actually born with. Another thing to note is the sacral region, which we'll talk about once we get down into the pelvis, so you can see the sacrum down in here. So again, we have the lordotic curve at the cervical spine, we have the kyphotic curve at the thoracic, and then we come again with a lordotic curve at the lumbar spine. Again, the cervical and lumbar being what we call secondary curves. Okay, both of the lordotic curves are deemed secondary curves. And then if you notice the center of gravity in the head, so the center of gravity of the head falls on the concave side of the curves. So if you're looking at this, so here's your center of gravity, okay, your line of gravity working through, and you see that in each one of the curves, that line falls on the concave side. Okay, so for instance, the cervical spine here is concave posteriorly. Okay, the thoracic curve is concave anteriorly, and then you have the concave side on the posterior surface, on the posterior side of the lumbar spine. So when we're looking at the spinal alignment and posture, when we have our movements in flexion and lateral flexion, one of the things we want to make sure is important, for instance, you know, as an athletic trainer, when I'm assessing movement at the spine, I want to make sure that there's no flattened areas or areas of angulation. In other words, when I watch somebody laterally flex their spine, I want to see symmetry in motion. I want to see the motion occurring throughout the entire lumbar spine. I don't want to see any abrupt areas of change as individuals are going through movement. Again, I don't want to see any flattened areas. So, you know, when I have someone go through spinal flexion, I want to see even flexion throughout their spine. I don't want to see any flattened areas where there's not any real flexion taking place, because that's going to show where there's areas of stress. Same thing with lateral flexion. I want to see nice even motion kind of going throughout the spine and have it be pretty even throughout. So when we're looking at certain structures of the spine, there are certain unique areas we want to talk about. So at the cervical vertebrae, we know that we have the first and second cervical vertebrae are unique. Those are known as the atlas and the axis. So when we look at those first two vertebrae, they're going to be much different than the other five that you have, the atlas and the axis, and we'll talk about the movement that's going to occur with them. One unique thing, if you remember about the cervical vertebrae, is that they all have processes for the vertebral arteries to pass. So they're the only vertebrae that when you look at them have vertebral foramen. That's how one of the ways you should always be able to easily tell you're looking at a cervical vertebrae. They're the only vertebrae that has those. As we get into the thoracic and lumbar vertebrae, one of the things about the thoracic spinous processes is they tend to be directed downward. So if you're looking at a skeleton, you're looking at those thoracic vertebrae, the spinous processes have a downward orientation to them. The lumbar spinous processes are very thick, okay? Really everything about the lumbar vertebrae are very thick and heavy. That's because that's where you're going to be bearing most of your weight. At the sacrum and the coccyx, the posterior dimples that you will see in the back kind of demarcate the sacroiliac joints, which is an important joint to discuss when you're talking movement. There's also the potential to have pathology and injury at those areas. The coccyx, or the tailbone, sits right at what's known as the gluteal eminence, so right at the top of the glutes you could find that. And then when we look at the ribs, so something, it's just a kind of note about the ribs. So ribs 1 through 7 have a direct attachment to the sternum. Okay, so those are what we call the true ribs, as they go directly to the sternum. Ribs 8 through 10 have an indirect attachment through that costochondral arch. They're known as the false ribs. So they don't have a direct attachment to the sternum. They do attach to the sternum, but they attach through a broad kind of cartilaginous portion that kind of makes then the articulation with the sternum. And then ribs 11 through 12 are floating ribs. They have no attachment to the sternum. And one of the things that we look at, because obviously we know the ribs do also have an articulation with the thoracic spine, when you have an individual with scoliosis, for instance, okay, or that lateral deviation of the spine, that impacts the ribs. And a lot of times individuals that have a really bad scoliosis, it could also affect their breathing, because we obviously know that the ribs obviously surround the lungs. And if there's that lateral deviation and also that rotational component to scoliosis, that's going to kind of change the anatomical orientation of the ribs. So when we're looking at the motions of the vertebrae, it's important to note what a motion segment actually is. So to just define what a motion segment, because the spine is a pretty complex area to look at. There's more than one joint that kind of makes up a vertebrae. There's a bunch of soft tissue, and obviously you have the disc. So a movement segment at the spine consists of these things. It consists of the 2 adjacent vertebrae, so the 2 vertebrae that are immediate to each other, your 3 intervertebral joints, okay? So the 3 different intervertebral joints, so that's the articulation between the vertebral bodies, the discs, the longitudinal and segmental ligaments, which we're going to talk about those, and the capsules of all the facet joints, okay? So remember, you have the facet joints and you have the intervertebral joints, which are where the vertebral bodies come together. Those are the 2 joints that we're going to be looking at when we kind of discuss what goes on with the spine. And when we're looking at the degrees freedom of motion in most of the joints, okay, you're going to be looking at 3 degrees freedom of motion. Okay, you're going to be looking at flexion, extension, rotation, and lateral flexion. Okay, and essentially the disc and the right and left facet joints is really where is going to produce motion at the other 2 joints. So that's an important thing to note. When we're looking at the 2 types of joints that we talked about, the intervertebral joints and the facet joints, the intervertebral joints are ampiarthrodial. And they're ampiarthrodial because they don't have a joint space. That's where the discs are. Okay, so the lumbar spine has the discs. The facet joints are plane joints. Okay, so they're the plane joints with the 2 flat surfaces, and they also have a joint capsule. So your osteokinematic motions at the spine are just what we talked about. We have those 3 degrees freedom of motion. You have flexion and extension, you have lateral flexion, and you also have rotation. So the spine is really the only place in the body where you laterally flex. You don't do lateral flexion at any other region in the body. Now, your arthrokinematic motions are a little different than what we talked about before. You have very specific arthrokinematic motions that occur at the spine. You have anterior posterior shear, you have lateral shear, and then you have distraction and compression. So this is a little different than what we talked about at some of the other joint regions in the body. So anterior posterior shear is that shearing force. If you don't remember what a shear force is, go back and look in the first chapter in discussing what a shear force is. But anterior posterior shear is obviously leading in an anterior posterior direction. Lateral shear is going laterally through the spine. And then distraction compression. Distraction is essentially just pulling the vertebrae apart. Compression is pushing the vertebrae together. Okay, those are your arthrokinematic motions. So a little different discussion here with that than what you have at some of the other joints in the body. So one of the easy ways to look at the spine, and this is a good thing just even as a clinician that you do, is because there's so many different anatomical structures in the region to break the spine up into sections. So for instance, here we're going to look at what we call the anterior joint structures. So the anterior joint structures, and again, this gets even more important, like, from the standpoint, for instance, from my standpoint as an ATC, when I'm doing an evaluation of the spine, again, there's so many structures around to really kind of narrow it down. And many times clinically, there's more than one structure involved with an injury, but you have to be able to think about, the anterior structures versus the posterior structures and kind of what that means as far as movement pathologically. So our anterior structures that we're going to look at are the bodies of the vertebrae, the discs, and the longitudinal ligaments, okay? So the discs, as we look at them, and you can see a picture of the disc illustrated here, they're resistant to compressive forces. Okay, so the vertebral joints or the intervertebral joints are ampiarthroidal joints that are filled with the discs going throughout the spine. So they're resistant to compressive forces. They also protect the facets, okay, the facet joints in the posterior aspect of the spine, and allow for limited movement within the intervertebral joints. So they take some of the stress off of the facet joints. Now, when we look at the parts of the disc, so you can see looking at this, I always look at the disc like you could think of the disc as a jelly donut, okay? You have the annulus fibrosus, which is the outer portion. So think of the outer portion of the jelly donut, and then you have the jelly inside, which is the nucleus pulposus, okay, which is kind of like a watery filling, okay? You also have the vertebral end plates, which are at the positions right around where the disc kind of articulates with the actual vertebral bodies. If you notice that the fibers run in an oblique pattern, okay, and what they do is to just kind of strengthen and maintain that nucleus pulposus. So if you've ever heard of a herniated disc, which we're going to look at in the next slide, that's when that annulus gets compromised and that nucleus pulposus gets distorted in some fashion. The discs are also what we call hydrophilic, so they retain water. Over time, though, due to the aging process and maybe even repeated microtraumas to the discs, they do tend to lose water. So that's where people will end up with things like degenerative disc disease and things like that over time. If the disc loses water, which again can happen as of aging or due to minor trauma or major trauma even over time to the spine. So if we look at the force transmission of the disc, so again, in most loading situations of the spine, the force is not applied directly through the center, okay? So you have a compression-tension relationship based on movement. So again, we're getting back to some terminology that we had talked about and discussed earlier in the year, talking about compression versus tension. So there's going to be compression near the force side and tension on the other. So for instance, if you're looking at this illustration, you could see with flexion, you have compression on the anterior surface, you have tension on the posterior surface. And with extension, you have just the opposite. So again, refamiliarizing yourself with anatomy. So you're looking at so these are actually thoracic vertebrae. You could tell they're thoracic vertebrae because the spinous processes are long and they're pointing downwards. So we're actually looking at a picture of the thoracic spine here. And you can see, so your facet joints are right here. This is where on the posterior side, this is your intervertebral joints with your discs, okay? So with the discs, there's different pressures based upon positioning, okay? So while you have different forces with movement, just even with positioning too, you have different forces being placed. So when you lie down versus when you're standing versus when you're sitting, you have gradually increasing amounts of pressure being placed on the disc. For instance, when you're lying down, you have really next to no pressure on your discs. You're not weight bearing. When you're standing and then when you're sitting is even more pressure on the discs. So if you think about it, when you're sitting, that increased pressure because now you have pressure coming from both sides of it, that's going to add added stress to the disc, okay? And again, you can see with movement, the nucleus pulposus tends to migrate with flexion and extension. So it's going to migrate posteriorly with flexion, and it migrates anteriorly with extension. With rotation, it moves to the opposite side. So if you rotate to the right, it gets pushed to the left. If you rotate to the left, it gets pushed to the right, okay? And again, that's normal positioning, but again, when you get into extremes and you load that, that's then when you run the risk of, as they call it, getting a herniated disc. Here's the longitudinal ligaments. So these are still a part of that, what we call the anterior portion, or as I also sometimes refer to it as the anterior column of the spine. So if you're looking here, here's the anterior longitudinal ligament. So it covers the front part or the anterior part of the vertebrae. Here's the posterior longitudinal ligament. So you can see that posterior longitudinal ligament kind of lines the posterior surface. So here's your vertebral body and here's your disc. So you can see that whole area is kind of wrapped in both an anterior and a posterior longitudinal ligament. Again, if you think about how these ligaments would limit motion, the anterior longitudinal ligament is going to limit extension. Okay, it also supports that lumbosacral convex shape that it has. The posterior longitudinal ligament is going to limit forward flexion. It also generally has lower tensile strength than the anterior longitudinal ligament. So the anterior longitudinal ligament is a little bit stronger. The posterior longitudinal ligament also helps the vertebral body withstand some compression forces. So, and it should also be noted that the posterior also tends to narrow a little bit as it goes down the spine. So there tends to be greater stabilization if you think about most of your disc herniations are going to occur posteriorly. So this posterior longitudinal ligament, we're going to talk about all these other ligaments later. They're on the posterior side. This posterior longitudinal ligament tends to get a little thinner as it gets downward towards the spine. So there tends to be a little greater stabilization of the posterior longitudinal ligament to the disc up in the cervical spine versus the lumbar spine. That's why you hear so many times of the lumbar spine having so many disc herniations in it, partially because that ligament gets a little bit thinner and isn't quite as strong as you kind of move down the spine. Okay, so now when we look at the posterior joint structures, so the posterior joint structures are going to consist of the bony arches, the various bony processes, the facet joints, the joint capsules, and the various ligaments on the posterior side. So here we're kind of looking at this region. So basically your facet joints, which are these joints right in here, okay? So you can see the joints where the facet, the articulating facets come together on the posterior surface of the spine. You have the ligaments back on the posterior side, the ligamentum flavum, the supraspinous ligament, and the interspinous ligament. Okay, here you can see where the facet joints come together. So this picture could be a little confusing versus what we call these anatomically, because they're showing here the superior zygoapophyseal facet, which is the same as just saying the facet joint, the inferior zygoapophyseal facet joint. So it's just referring to that as when the joint comes together. So if you were just looking at like this vertebrae, for instance, and having to identify the different structures, okay, so these would actually be your superior facets. These would be your inferior facets. They're just calling this way because they're looking at the full articulation, but don't confuse that with the anatomical landmarks that you've already learned, okay? So the function of the facets, since we're talking about them, is to control motions and actually protect discs from excessive force. So the discs and the facet joints, because they kind of make up two different joints in the spine, they kind of help each other out, okay? Another thing when you're looking at the facet joints, the inferior articular process, which again is when I'm saying inferior articular process, I am actually referring to this one here. So this and this, okay? So again, this picture is a little confusing. This is the inferior articular process. They face anterolateral. The superior articular processes face posterior and medial, okay? So that's why they come together at the actual joint, okay? Some of the other structures, you have the ligamentum flavum, which connect the lamina. You have the interspinous ligament, which connects the spinous processes. You have the supraspinous ligament, which connects the tips of the spinous processes and also connects to a thick band of tissue called the thoracodorsal fascia, okay, or it's also known as the thoracolumbar fascia. And you have the intertransverse ligaments, which you can't see in this picture, but if you think of the name, so you should know all your processes, okay? So the transverse process, the intertransverse ligament would connect all of the transverse processes together, okay? For the facet joints, if we look in a closed and open packed position of the facet joints, the closed packed position of the facets is extension. So when you're in extension, the facet joints will be close together. And when you're in flexion, they're open, okay? The intervertebral joints don't have an open and closed packed position because they're not a diarthrodial joint. Again, they're filled with the disc, so they are not a diarthrodial joint. So we look at the posterior joint surfaces. We look at the idea of what are called coupling motions. So what this is that when you have two motions that kind of interact with each other, so the combined motions that occur because of the structure of the vertebral column, and plus to the orientation of the facet joints as I described, and the limitation by some of the soft tissue structures. So the most accepted coupling motion is looks at rotation and side bending. So basically when you do side bend, so when you do lateral flexion, you do get a little bit of rotation, and when you rotate, you do get a little bit of side bending. So if you go in side bend or you laterally flex, you do get a slight amount of rotation, and when you rotate, you do get a slight amount of side bending. So that's all that means with the coupling motions, and again, that's just simply because of the structure of the facet joints and some of the other soft tissue structures that surround the region. So now we're going to look at some of the unique things up in the cervical region. So as we look in the upper cervical spine, we have some unique structural things going on there. So the upper cervical region consists of the occiput C1 and C2. Okay, and you could already see some of in the picture up here. Okay, you have C1, which is the atlas, C2, which is the axis, which are much different than the rest of the cervical vertebrae that we're looking at. So at the atlanto-occipital joint, we have 2 degrees freedom of motion. So the occiput would be sitting right on here, the base of your skull. Your 2 degrees freedom of motion there would be flexion and extension, and some lateral movement, lateral flexion. Mostly the the flexion and extension tends to dominate the range of motion there, but there is some contribution to lateral flexion. At the atlantoaxial joint, so you have the axis, which has the dens coming off it, and that kind of fits and sits right inside the atlas. You have 1 degree freedom of motion, which is rotation. As we move down to the rest of the cervical spine, so C2 through C3 through C6 and C7, you tend to see a gradual change in the facet orientation. So as you look at the facets, and it may benefit you to even look at an actual model of the cervical spine, you'll notice that the facet joints go from a horizontal plane to almost a 45-degree angle between the horizontal and frontal, okay? So there's that gradual change which allows for, the movement to take place. And with movement, the superior articulating facet moves. So when you flex your cervical spine, the superior articulating facet tends to slide superior and anterior. And when you extend, the slide tends to go inferior and posterior with the superior articulating facet. When you laterally bend to the right, the left side moves superior and anterior, okay? And then obviously when you would lateral bend to the left, the right would move superior and anterior. So that's what the articulating facet is going to do, meaning the superior one, as you go through the movement. Your normal range of motion for the cervical region, so you could kind of look at this overall with a person. Everybody should basically be able to touch their chin to their chest, and when they extend their neck, their chin should form a vertical line with the chest. In other words, when you fully extend your neck, you should be able to drop a line straight down from your chin to your chest, which would tell you that you have normal extension range of motion. We get into the thoracic region. So some of the responsibilities of the thoracic region are to support and permit motion of the trunk and head. Obviously, too, there's the protection aspect, particularly with the ribs to protect the heart, lungs, the great vessels, also to supply articulations for respiration. So we know that in order to breathe, we need attachments of the muscles of respiration and some of the accessory muscles that help with that as well. The facet joints, as you notice, get to be orientated much more to the frontal plane. This tends to limit extension. However, as you start to get more into the lower thoracic vertebrae, this starts to change, okay? So for starters, the lower thoracic vertebrae tend to be less restricted by the ribs. So part of the reason why there's just limited motion in general at the thoracic region is because the ribs attach. So the ribs limit the motion a little bit more than what you would have in the lumbar versus the cervical region. And the lower thoracic vertebrae, the orientation of the facets tends to take on a more sagittal orientation. So the movement, once you get down more into the thoracic spine, tends to be a little bit more like what the lumbar spine is. So the lower thoracic vertebrae tends to be more amenable to more flexion and extension range of motion versus and side bending with less rotation. Okay, so like very similar to what you get with the lumbar spine. Okay, as opposed to the upper thoracic spine. So again, take a look at just some pictures and illustrations and models that can kind of delineate this, and you can be able to see a little bit more as far as how that takes place, because this is really important when you're thinking about movement at the spine and what it means as far as those facet joints to have the orientations that they have. Okay, so when we look at the thoracic region, another important relationship we have to look at is the relationship between the thoracic spine and the ribs. So the ribs form what are known as the costal joints, and costal joints are synovial joints, just like the other diarthrodial joints in the body, and movement has to happen there. So there's two different kind of arrangements that we look at between different groups of ribs. So if we look at the arrangement of ribs 2 through 9, ribs 2 through 9 are what we call typical ribs. So the anatomical orientation of the typical ribs, so this is an example here that I could use. So if we look here, This is where the 8th rib is. So for the 8th rib, okay, which would fall in that 2 through 9, the articulation occurs with the body of the vertebrae. So for the 8th rib, it would be T8. The body above, so you can see how, so basically the 8th rib would start right in here, and it would also have an articulation with the disc, okay, as well, because it would be in that region in between T7 and T8, okay? So that would be your typical ribs. What we call the atypical ribs are ribs 1, 10, 11, and 12. So those ribs only articulate with the corresponding vertebrae. So in other words, the first rib only articulates with T1. It doesn't connect to any other vertebrae. Same thing with 10, 11, and 12. So unlike rib 8, which connects to both T8 and T7, it has an articulation with both. These ribs, again, these are referred to as atypical ribs because they only connect to the body, the corresponding body that the rib is at. So in other words, again, rib 1 only connects with the vertebral body of T1, 10 only occurs with the body of T10, etc. So the ribs play a role, obviously, with elevation and depression, which assists us with breathing. Okay, so an elevation and depression basically consists of a pivoting motion through the costovertebral joint and the costotransverse joint. So the costovertebral joint is the articulation at the rib at the vertebral body, and then the costotransverse joint is the articulation between the ribs. So that rib 8 would come around here and also attach to also have an articulation with the transverse process. So that elevation and depression of the ribs creates a pivoting motion. Now it's important to note that the upper ribs have a more horizontal orientation, and their diameter increases anteriorly when you breathe. So when you take in a big deep breath, the upper ribs are going to take more of an increase their anterior diameter, whereas the lower ribs have a little bit more of an oblique angle, and they have more of a lateral projection when you breathe in. So if you notice, your lower ribs tend to move out, your upper ribs tend to move more forward, okay? And obviously, again, the ribs participate in respiration like we talked about. They protect organs. They also help to provide some stabilization for the thoracic spine. So those are the roles of the ribs as I just discussed. So here's another picture kind of showing that orientation. So this rib would be typical. So this is a typical rib, not an atypical. It's a typical rib, meaning that you have the articulation with the two vertebrae. You can see it also has a little articulation with the disc, and then it kind of, let me pull up the pointer, then it kind of wraps around, and you can see here's that costotransverse joint. So the rib kind of wraps around there, and you have that articulation. And again, so as you breathe in and breathe out, the rib is going to kind of pivot within that joint. It's a synovial joint, just like your other diarthrodial joints in the body. We look at the lumbar region. So the lumbar facet joints are going to move from a sagittal to a frontal orientation. What they do is they prevent rotation and anterior shear. Okay, so the lumbar facets are resistant to rotation and anterior shear. Then we get down to the lumbosacral junction. There's large anterior shear forces there, so it's important that the facet joints, and again, you can see that they take on a more frontal orientation as they move down. And you also have ligament-wise, the iliolumbar and the sacrolumbar ligaments are ligaments that kind of stabilize the lumbar spine to the sacrum and pelvis. Okay, the iliolumbar ligaments go from the ilium to the lumbar vertebrae, and the sacrolumbar ligaments go from the sacrum to the lumbar vertebrae. And they provide some stabilization down in the lower region of the spine. So a lot of significant soft tissue structures are present in and around the spine. You have the thoracolumbar fascia, which is something that gets talked about a lot. There's a lot of muscle connections to this, and it's a very broad structure It kind of functions almost like a really strong ligament, is probably the best way to describe it. It connects the ribs, the spine, and the sacrum, all kind of are tied in with the thoracolumbar fascia. And it breaks down into three different areas: an anterior, a middle, and a posterior. So you can kind of look at the picture up top. They kind of have a little cross section there where you can see. So in the anterior layer, the significant structures are the quadratus lumborum and the psoas. In the middle, you have the transverse abdominis. And then the posterior region is significant because that's going to be what attaches the spinous processes and the supraspinous ligament. So again, this structure allows for a great deal of stabilization, and it also attaches to the fascia of the glute inferiorly and superior to the spleni muscles. So you can see kind of the anatomical orientation down in here. There's actually a little connection to the latissimus dorsi as well. We talked about this actually in our strength and conditioning class, how we use the safety bar squat, which has handles on it, as opposed to doing a regular squat when your shoulders are in that abducted and externally rotated position. And the students are finding that, well, I can get a little deeper in a squat when I use a safety squat bar and I don't have my shoulders up. Well, the reason why is when you have your arms held in a position similar to what you do in a typical barbell squat, it puts tension on your latissimus dorsi. And the latissimus dorsi, while it's a shoulder muscle, has a connection. It originates down in the lumbar spine and pelvis off the thoracolumbar fascia. So if your lats are tight, that's going to influence the positioning of your pelvis. So you can see how that thoracolumbar fascia really does act as a stabilizing unit, but it's really important to make sure that those muscles surrounding it that attach to it have good enough mobility, because if not, it could create a great deal of tightness and could possibly iliminate some of your motion. So that takes us down into the sacrum. So if we look at the sacrum, the sacroiliac joint is a diarthrodial joint. It's a plane joint, okay? It's going to have 3 degrees freedom of motion. So at the sacrum, now again, much like the spine, we have some different motions that take place. So you're going to have anterior and posterior rotation, which occurs in the sagittal plane. You're going to have abduction and adduction, which happens in the frontal plane. And you're going to have medial and lateral rotation, which happens in the transverse plane. Okay, so those are the 3 degrees freedom of motion that you have at the sacrum. So those motions are going to be what we look at. So, again, coming in here, you're going to have your anterior and posterior rotation. Here's your medial and lateral rotation, and then add an abduction. Now, there's also kind of a secondary motion that occurs at the sacrum. It's called nutation and counternutation. So all this refers to is movement of the sacral promontory. So, for instance, when you look up top, you can see, so the sacral promontory is that front portion of the sacrum. So with nutation, if you see up here, as the person moves their trunk forward, okay, which would basically cause an anterior rotation of the pelvis, you get a complementary motion of what's known as nutation with that. So with nutation, the sacral promontory moves inferiorly and anteriorly, and the distal sacrum and coccyx, or the tailbone, moves posteriorly. So here's where the sacral promontory is. So as the nutation is occurring, it's moving anteriorly and inferiorly. The coccyx is moving posteriorly. When you have counternutation, or you kind of extend the torso backwards, so again, here's your sacral promontory. In this case, it's going to be just the opposite. Now the sacral promontory is going to move posteriorly, and now the sacrum and coccyx is going to move anteriorly. Okay. Many times there's issues at the SI joint. This is kind of a practical point to look at. There's a lot of issues with pregnancy at the sacrum because of all the forces that take place at the pelvis. When you have pregnancy, there's a hormone that gets released called relaxin. So what relaxin does is it relaxes all the ligaments, and in particular for the sacrum and pelvis, that's important for childbirth. But the issue is prior to the child being born, you still have that hormone getting released, which can happen and create a lot of issues with increased laxity around the SI joint. So it's not uncommon for women who are pregnant to end up having some issues with their SI joint because of that. They tend to be a little bit more lax than what they typically are. The SI joints are pretty strong joints, and they don't permit a whole lot of joint play, if you will. But for a pregnant female, having those hormones getting released does make it a little bit more lax, which, you know, again, could create some issues with back pain with pregnant women. So another thing when we look at the sacrum, so it's important when we look at weight distribution with standing and walking. So when we look at the weight distribution with standing and walking, and again, this goes all more to the point why this has to be such a stable area, okay? So when you're standing and walking, the force goes through the fifth lumbar vertebrae, through the pelvis, the hips, and the femur. And what this is going to do is it's actually going to push the sacrum distally and anteriorly, while the ilia go proximally and posteriorly. So what this is going to do is create almost like a clamping mechanism when you're bearing that weight. Okay. So again, the forces are going to go through the fifth lumbar vertebrae, through the pelvis, hips, and the femur. It's going to push the sacrum distally and anteriorly, and the ilia proximally and posteriorly. So again, this is going to create a clamp, kind of like a clamping mechanism. It's kind of what they're showing here. That's going to help to stabilize that region. Now, the weight distribution with sitting is obviously a little different because now you're going to have more direct pressure on certain areas. So when you're seated, you're going to have more pressure through the pubic symphysis and the ischial tuberosities because of obviously sitting on your chair or your surface that you're on, okay? Also looking at some of the ligaments, so the posterior ligamentous complex tends to be much stronger and thicker when you're talking about the sacrum, and then your other important ligaments, the sacrotuberous and sacrospinous ligaments. So the sacrotuberous ligaments they both connect the sacrum to the ischium. So in the case of the sacrotuberous ligament, it connects the sacrum to the ischial tuberosity, and in the case of the sacrospinous ligament, it connects the sacrum to the ischial spine. Sorry for that minute, I had to think about that. And their job is to just limit tilting of the sacrum. So they kind of help to stabilize. So one of the things when you're assessing SI joint problems, if the individual has, you know, some sort of sacral torsion going on down there, you would actually feel how taut or how loose those ligaments are, and many times that could kind of tell you what you're sort of dealing with as far as an SI joint dysfunction if that were to be taking place. So with the pubic symphysis, we look at what type of joint is the pubic symphysis. So the pubic symphysis is an ampiarthrodial joint. So remember, it has a little cartilaginous articulation. There's no joint space, but there is movement that takes place. There's muscular reinforcement in and around that area. The muscular reinforcement consists of the rectus abdominis, the internal oblique, and a small little muscle at the base of the abdomen, which you probably haven't heard of until you've read this chapter, called the pyramidalis muscle. So the pyramidalis muscle is a small muscle located at the very base of the abdomen, and that's also going to attach at the pubic symphysis. You could get dysfunction, and you get joint dysfunction and injuries here as well. Actually, a lot of individuals that have SI joint dysfunction tend to also have some subluxations take place at their pubic symphysis. So, however, you can have more direct trauma. So, for instance, when you land on your feet uneven from a jump, auto accidents, leg length discrepancies can cause that as well. Obstruction of hip flexion. So I always bring up the example of, you know, if in football, when a punter is going to kick the ball, if another player comes and blocks the punt and also hits the punter's leg, that could actually be a mechanism for a subluxation of the pubic symphysis. Obviously, direct trauma to the region can occur as well, but that's where you would have some possible issues at that joint. Then you have the coccygeal joints. Okay, so the coccygeal joints, we're now down into the tailbone. Those are synarthrodial joints, because again, that's kind of a fused joint. So the 3 to 5 vertebrae that make up the tailbone, they fuse together. Okay, so we have two different articulations here. We have the sacrococcygeal, that's where the sacrum and the coccyx join together. There's usually there begins there early in life a fibrocartilaginous disc, so that joint could actually start out being ampiarthrodial, but as you age, that joint fuses, and then you have the intercoccygeal joints, and that's the again anywhere from 3 to 5 vertebrae that make up the coccyx, or what we call the tailbone. So we look at the muscles of the spine. We look at, again, just kind of general function that we're going to kind of examine. So anytime we have bilateral contraction, that's where you're going to have your flexion and extension taking place. Your unilateral contraction is going to be working on side bending or rotation. It is important to note that most of the time, the muscles around the spine are primarily acting as stabilizers. So, you know, while we do have movement that takes place at the spine, just because of the fact we walk upright and because we do a lot of things with our extremities, while the muscles of the spine do create movement, their primary function is to work as a stabilizer. All right, so now we look at some of the functional activity of the muscles kind of based upon just things we do in daily living and some of the other factors. So again, prior to getting into this is why it's so important to understand the, I guess, basic functions of the muscles. In other words, just the anatomical general functions of the muscles, because now when we get into some of this stuff, again, in biomechanics, we're going to be talking about some different functions that they have, not so much that they're, you know, again, we get away from the basics too far, but this is what's going to happen in real life, because again, we're human beings, we're in different positions, we do different things, and different types of contractions are going to occur. So obviously we know when we look at the musculature around the spine, if you just think about our day-to-day living, really the overall function of the muscles and everything that surround the area is to balance the head and vertebral column, because we're upright. Okay, we stand, we walk, we sit upright. Okay, unless you're lying down, those muscles have to be functioning. Okay, and while again, you know, for instance, the rectus abdominis produces trunk flexion. You know, that's what we talk about, like for instance, with just the basic, you know, the basic functional anatomy definition of what muscles do. But when you're talking about standing, sitting, leaning over, and things like that, the muscles are going to do slightly different things based upon how gravity is impacting the body. So first of all, we're simply going to look at the areas and the muscles involved. So the anterior muscles, we have the suboccipitals, which are the small little group of muscles that sit right at the base of the occiput. You have the scalenes, you have the sternocleidomastoid, you have the rectus abdominis, you have the abdominal obliques, and you have the psoas muscle. So the psoas, even though it's a hip muscle, it does attach to the vertebral column. It originates on the lumbar vertebrae. The muscles classified as posterior, the suboccipital muscles also fall into the posterior category because of their orientation, and the erector spinae, or the paraspinal muscles. Okay, so those are the posterior muscle groups. And then the lateral muscles, the scalenes fall into that. The sternocleidomastoid does as well. The quadratus lumborum, the psoas, and the internal oblique. So you see that some of the muscles do cross over categories because of their orientation and their function. Okay, most of these muscles, even at rest, show minimal do show minimal activity. When you talk about like quick changes of position and things of that nature, there's obviously greater muscle contraction. And when we're talking about the activity, particularly between the anterior and posterior muscles with concentric and eccentric contractions, a lot of this is going to be based upon the center of gravity and your base of support. Okay? So here's a really good activity to kind of see, again, this concentric-eccentric relationship relative to gravity and your body position, okay? So if you were to just sit at the edge of your chair and shift back from the edge, okay? So if you were to just kind of lean back a little bit, okay? So you sit at the edge of your chair and lean back a little bit, what do you notice, okay? And interestingly enough, what you'll know is that your rectus abdominis has to contract, because why it's contracting is you're leaning backwards. The rectus abdominis is actually starting to contract eccentrically to stabilize yourself. Same thing shifting forward, what do you notice, okay? So if you feel your paraspinals, they'll start to contract because they're contracting eccentrically to stabilize. So this is why you have to, again, start with that. We know that the rectus abdominis flexes the trunk. The erector spinae do extension of the spine, or trunk extension. However, based upon what it is you're doing, how gravity is impacting it, you have concentric and eccentric contractions. So you have to have a starting point in being aware of that functional anatomy before you get into analyzing movement, or else you're not going to be correct with how you're analyzing your movement and what muscles are active. So when we're talking about trunk motion and stabilization, so the erector spinae, or the spinal erectors, they're going to do extension, rotation, and they do contribute a little bit of side bending. The back muscles will act as synergists to prevent unwanted movement. So for instance, when you just want to do trunk rotation, we saw a little bit of this when we were talking about the wrist and hand, but when you just want to rotate your trunk, okay, so we know that we have the external abdominal obliques, the internal abdominal obliques working, but the erector spinae is also going to work to prevent flexion, because think about it, again, if the erector spinae didn't kick in when all you wanted to do was rotate your trunk, what would happen? You would end up flexing, because the external, particularly the external oblique, there's a little bit more trunk flexion than the internal, but you would get some flexion of your trunk taking place. When we talk about side bending, so side bending or lateral flexion takes place in the frontal plane. That what you're really getting when you're standing in an upright position is that you're getting a contralateral eccentric contraction of the lateral musculature. So you're not so much contracting the same side concentrically. You're actually getting an eccentric contraction from the opposite side. So the multifidus and transverse abdominis are deep muscles. These are primarily stabilizers. They don't necessarily produce, the bigger gross movements of flexion, extension, lateral flexion, rotation. They're active more as stabilizers. And one of the things we talk about consistently from a clinical perspective is the concept of neutral spine. So we try to maintain a neutral spine through stabilization, and that's really the best place of function to reduce the stress on the back. So that's pretty much the midway between an anterior and posterior tilt of the pelvis. It's just basically maintaining the curvature of the spine as best you can. Now again, the spine does have joints and the spine can move, but you want to teach neutral spine and stabilization first, and then allow the person to gradually start to increase their range of motion at the spine and work through that. So again, trunk motion and stabilization, the trunk has to be able to stabilize in order for the extremities to move. The other thing we have to note is the close relationship here with the hips, okay? So, for instance, in closed chain motions, the psoas is a major contributor to stabilization and movement. So, and not only do the hip muscles that directly attach to the spine have an influence, but just the hip muscles in general, when we do activity, as we're going to see in the next couple slides, they also control a lot of our spinal movement as well, kind of indirectly, and we'll see that as we get into some of just the functional movement stuff that occurs. So let's talk about forward bending and lifting with the knees extended. Okay. So obviously we want to make sure that when we're bending over with the knees extended to touch the toes, and I'm seeing this as tough toes, it should say touch the toes. What are the hip muscle actions? So I'm going to hold on this. I mean, you could actually read about it, but I'm going to bring this up more in class. Think about what the hip muscle actions here need to be, because the hip has to contribute to this movement. Okay, so that's a significant thing. So bending forward to touch the toes, what are the hip muscle actions? I want you to think about it. You can read about it in the book, but we're going to bring this up in class when we meet to have our discussions. There is a critical point with this where you're forward bending with your knees extended when there's what's called a sudden inhibition of the paraspinal. So what happens is the posterior spinal ligaments will get stretched and cause reflex inhibition of the muscles. So essentially, that's a fancy way of saying the muscles kind of just shut down. The issue with that is there ends up being a significant load on the ligamentous structures and on the facet joints. So you'll hear people talk about, well, geez, all I did was bend over to pick up a pencil that I dropped, and all of a sudden my back went out. Well, that's what happens. So part of the issue was they probably didn't hinge and bend the way that they were supposed to. But basically what ended up happening was the passive structures in the facet joints ended up taking on more of the force, and that ended up causing the issue where they ended up having an injury. So again, still looking at forward bending with the knees extension. Again, there's going to be large flexion moments because of the hip extensor muscles. So there's going to be large leverages there. You do get passive support by structures when the spine is in flexion. So again, those passive structures, the posterior ligaments, the facet joint capsules, the thoracolumbar fascia. So those are all things that kind of come into play with that. Again, you don't want too much stress being borne on them, because if that's the case, then that's where, again, a lot of your injuries and things like that can occur. So trunk extension from full flexion, we would like that activity to be initiated by the hip extensors. If we get the hip extensors to do that, it actually puts less stress on the spine. So, and part of the reason why you'll get that is you'll get contraction of the transverse abdominis and internal oblique to increase tension on the thoracolumbar fascia. That'll help in stabilizing. And that'll allow for you to get what's called an abdominal brace. So an abdominal brace is basically your anatomical weight belt, if you will, that kind of helps and assists in stabilizing the spine. So it's important that your hip extensors initiate this movement, because of the fact we know that we have the erector spinae, which can extend the spine. However, when you're in this position of having yourself bent over forward with your knees extended, the alignment of the erector spinae ends up becoming parallel with the vertebrae, which basically means there's not a very good extension moment present. In other words, the position of the erector spinae in that position really doesn't lend itself to being able to really help with extending the spine. So that's why the hip extensors really need to be strong in order to do that. Another important aspect, again, because remember the latissimus dorsi, while it's a shoulder muscle, does originate down in the lumbar spine and has a connection to the thoracolumbar fascia. So when the arms are fixed, you actually can get some latissimus dorsi contraction. We talked about this in our strength and conditioning classes when we discussed the deadlift. Getting the latissimus dorsi tensed prior to the deadlift to further help in stabilizing the spine, because again, that's going to further put that thoracolumbar fascia on tension. Now we look a little bit more at squat lifting. We kind of talk about the difference at what happens with an anterior versus a posterior tilt. So be thinking about what happens to the curve at the lumbar spine when you have an anterior or posterior tilt. So an anterior tilt kind of encourages more of that lordotic curve. A posterior tilt flattens it out. Okay, so the the importance of that again puts the muscles in a better activity. You get greater muscle activity actually with an anterior tilt because it's going to put the muscles in a more favorable position. So think about it when you're squat lifting or lowering to pick something up. Again, I'm going to ask the question here, what is the muscle activity taking place? So this will be another thing that we address in class because I think from overall function this will work. You can get a heads up on it and read about it in the textbook. But again, it's an understanding thing as to what is actually happening. Okay, so we're gonna further that discussion actually in class. Again, the differences in the erector spinae posture between an anterior versus a posterior tilt. Having the slight anterior tilt is going to put the erector spinae in an actual better position for contraction. If you do go posterior tilt and flatten out or try to encourage more of a kyphotic curve in the lumbar spine, you're not going to get any initial contraction. You're only going to get a contraction at the end of the lift, which again isn't going to be very good for the structures in the region when you're actually going through the movement. So again, more functional activity related to the extremities. So if we go to the push-up example, so in a push, the example of a push-up with any type of pushing movement, okay, you should really be in what's called an anti-extension posture. So your abdominals and hip flexors should be working, and you should be putting yourself into, again, what's called an anti-extension posture. So if you think about a lot of people when they're weak, particularly in their abdominals, they tend to hyperextend their spine when they're doing push-ups. Okay, that's one of the normal compensations that you'll see. So pushing, you should be in what's called, again, an anti-extension posture. When we're talking about the lower extremities, so lower extremities require synergistic activities of the muscle and torso. So again, when you're going through various types of motion, again, there's a very high correlation with the lower extremity and the relationship of the muscle activity at the spine. And a lot of this relates back to, again, the forceful activities require stabilization of the trunk. So we talked about the anti-extension movements earlier. There's also anti-flexion movements. So anti-flexion movements would be anything where you're pulling, okay? So anytime you're functionally pulling something, your back and hip extensors should be working in an anti-flexion manner so that you don't end up putting yourself in a flexion posture because you don't want to when you're actually pulling something, okay? So pushing abdominals and hip flexors for anti-extension, pulling back and hip extensors for anti-flexion. All right, so breathing and coughing. So again, when we're talking about breathing at rest, really you're utilizing your inspiratory muscles only. So the diaphragm, the external intercostals, and the scalenes. Because remember, at rest, expiration's a passive process. Okay. Now, when you start to get into forced expiration, now you're getting into the abdominals and the internal intercostals, but that's only when you have some sort of labored breathing because, just even think of exercise when you're getting a little bit more forced expiration, that's where you're using those. But expiration at rest is a passive process. It's just a return, your ribs and everything return back to where you were. So forceful breathing and coughing, again, you will have that forced expiration, plus you'll also use your accessory muscles of inspiration. So things like the sternocleidomastoid, the pec minor. You can actually get the lats to help as well. So that's many times, we rest our hands on our thighs, and part of the reason why we do that is that actually tenses the lats, and that actually helps them with breathing. So they're not typically considered a major breathing accessory muscle, but that's part of the reason why it gets easier to breathe when you actually put your hands on your thighs. And then stabilization when coughing. So when you actually cough, your back extensors will actually contract to stabilize you, so you don't kind of throw yourself forward. So small little functional thing there, but one nonetheless. All right, so we're going to discuss the TMJ, or the temporomandibular joint. So first we'll just kind of look at the motions that occur at the jaw. So you could open and close. Okay, obviously we know that. We could open and close our mouth. Okay, our opening capacity should be about 3 fingers width. Okay, so you should be able to basically take 3 of your fingers, open your mouth. That's one of the ways we actually test. So like if I were to have a patient who takes a, they get hit in their jaw and they're complaining of jaw pain, one of the things I will look to do is test their opening capacity and make sure that they have enough range of motion there that they didn't lose any of that. So with the TMJ, you open and close. You have protrusion and retrusion, so you could kind of make your mandible kind of move forward and back, and you could do lateral deviation. Okay, so we've all kind of seen that. So the TMJ consists of bilateral synovial joints. Okay, we have our same thing. We have our concave and convex surfaces. Okay, so the convex surface is obviously coming off of the mandible. And inside there, we also have an articular disc, okay? So there's a disc that actually does sit in there, and what the disc does is it actually allows for a greater surface area. So it is still a synovial joint, but there is a small disc that does kind of float back and forth, because what that articular disc does is it allows, again, as I said, for some greater surface area to allow for greater and easier range of motion, okay? That disc tends to move forward in the condyles when the mouth opens up. So when you open your mouth, the disc, that little disc kind of shifts forward a little bit, and again, that creates some greater opening capacity. So the TMJ is what we call a movable hinge joint or a modified hinge joint. So it's not a hinge joint in the classic sense, like if we think of with an elbow. The elbow is like kind of your classic hinge joint, where you're only really moving in one plane. You have these added other subtle motions. So obviously the primary motions of the TMJ are to open and close. However, we know, think if all you could do with your TMJ is open and close your mouth. When you have to chew your food, it would be a lot harder to chew your food if you can't kind of manipulate your jaw a little bit more. So that's why it's very important. Another thing to kind of note with opening and closing is that you actually get rotational movement that precedes anterior translation. So when you open your mouth, you do get a little bit of anterior translation of the jaw, but you get more rotation that takes place first. Again, the orientation of this is you have the convex mandible on the concave glenoid fossa. So this is actually also known as the glenoid fossa when you talk about the TMJ. So TMJ dysfunction is important to note because this is something that could cause a lot of issues. I've never dealt with a patient from the standpoint of like a chronic TMJ dysfunction pain, but I've had at least 2 that I could remember, athletes who, in conjunction with head injuries, they basically got kind of hit in such a manner that the trauma caused a head injury, but also kind of affected their TMJ. So I have had to treat some TMJ issues. The muscles of mastication have a close relationship with the muscles of the upper quarter. So you see a lot of issues, particularly with like forward head posture. And a lot of people with forward head posture also tend to have some TMJ dysfunction. So a lot of your TMJ dysfunction can be caused by referred pain, whether it's acute injuries. Again, that's primarily what I've dealt with. Micro traumas to the jaw, or again, those postural dysfunctions. So again, if you think of a forward head, what that would mean as far as the muscular tension and the jaw, with the dysfunction that takes place when you look at a forward head posture, okay? So with a forward head posture, the cervical spine takes on there's two different issues, because you have to look at the upper and lower cervical spine. With the upper spine, the upper cervical spine, you're actually hyperextended, and the lower spine, the lower cervical spine is flexed. So what that does is, again, produces a lot of muscular tension and then gradually starts to impact the muscles that kind of surround the jaw and can start to produce some pain associated with that. And again, some of the trigger points and things like that that could form within that area. So these are our learning outcomes. So again, make sure that you look into those concepts. So if you don't know the muscle activity, or if you're unsure, or I would say this, even if you think you're sure, go in and check the book. We're going to discuss that. We kind of covered a lot of function in this lecture and discussion. So we'll be sure to point out some things and again bring some questions to class with you that we could address.